afternoon. My name is Nicole Silver, and in this case study, I'm going to discuss the diagnosis of Parkinson's disease, or PD, in a 53-year-old male. 1 year before he was diagnosed with PD, he was diagnosed with hypoosmia by an otorhinolaryngologist, and this condition is characterized by decreased capacity to smell. And the ENT concluded that he did not have nasal polyps, structural problems, or an infection, so he thought it was caused by allergies, but the allergy medication did not help the patient's sense of smell. After this, he was in a car crash and treated at the hospital for concussion. And a year after the patient was in the car crash, he went to his PCP because he was experiencing tremors in both of his hands and his right leg, and also rigidity in both of his arms. He said the tremors started about 2 months before he went to see his PCP, and he has no family history of PD, so the PCP referred him to a neurologist. At the time of his visit, the patient reported stiffness in both of his arms, which the neurologist concluded was cogwheel rigidity. Also, the patient said that his symptoms had started impacting his quality of life, such as his walking and his ability to complete small tasks around his house. Now, since the patient experienced tremors, rigidity, recent head trauma, and hypoosmia, the neurologist concluded that he had some form of PD. Also, the risk for PD is higher in older males. So the neurologist also checked for non-motor symptoms of PD like depression, anosmia, constipation, and rapid eye movement sleep disorder, which the patient did not have. So the neurologist ordered a DAT scan, which uses SPECT, single photon emission, computed tomography, and radioactive isotopes that bind to the dopamine transporters in the brain. This method effectively differentiates traditional PD from essential tremor and vascular or drug-induced PD. This is an image of transverse views of the brain using DAT scans. Now, the comma-shaped objects are caudate nuclei, and it also shows the putamen, which is at the bottom right of the caudate nuclei, and they both make up the dorsal striatum, which is connected via dopaminergic neurons to the substantia nigra. The normal patient scan shows symmetric caudate nuclei, whereas the PD scan has asymmetric and shrunken caudate nuclei, which is a telltale sign of traditional PD, and it also indicates decreased dopamine production. The DAT scan of the patient appeared similar to this one. Therefore, the patient was diagnosed with stage 2 PD. Now, Parkinson's disease is a progressive neurological disorder where the substantia nigra in the midbrain experiences a decrease in dopaminergic neurons. There's also a loss of Lewy bodies, and both of these result in a deficiency of dopamine, which causes the motor symptoms. Now, these motor symptoms are known as the classic triad: rigidity, bradykinesia, and tremors. And recently, research has uncovered non-motor symptoms of PD, which are due to problems with non-dopaminergic neurons. And early detection and treatment of these symptoms can greatly increase quality of life. Other recent research found prodromal symptoms of PD, including constipation, depression, and hyposmia. Now, clinical diagnosis of PD requires a 50% decrease in dopaminergic neurons and apparent motor symptoms. The discovery of prodromal symptoms of PD could lead to earlier diagnoses. If a patient has at least 2 of these prodromal symptoms, they have a higher risk of PD and should be regularly monitored for motor symptoms. Catching PD early would enable neuroprotective treatment with dopamine receptor agonists to slow disease progression. Research concerning neuroprotective treatment before the onset of motor symptoms is new and not yet approved, but it is dramatically progressing. However, exercise and a healthy diet can decrease the risk of PD. This patient has hypoosmia and recent head trauma, which increases his risk of PD. If he was notified of his increased risk, he could have been monitored for motor symptoms before he reached stage 2 of PD. The patient was prescribed with a combination of carbidopa and levodopa. And levodopa is a dopamine precursor that can cross the blood-brain barrier, and carbidopa prevents levodopa from converting to dopamine before it reaches the brain, and this replenishes the patient's low supply of dopamine. The neurologist prescribed the lowest dose of the immediate release tablet at 10 milligrams of carbidopa and 100 milligrams of levodopa, which is taken roughly 3 times a day, and the dose can be adjusted if necessary. And while taking the medication, the patient should avoid taking vitamin B or iron at the same time as the medication, and also avoid a high protein diet because this can decrease the uptake of the medication. The patient did not have any non-motor symptoms of PD, but will be monitored for them. And the patient should also follow a healthy diet and exercise. Now for some take-home points. PD is not just characterized by motor symptoms as traditionally thought, and treatment and detection of non-motor symptoms can drastically improve quality of life. PD also has prodromal symptoms that could lead to early detection of the disease. And even though we don't know the exact cause of PD, there are environmental factors like head trauma and exposure to chemicals that increase risk, as well as genetic factors. And PD is more common in older males. Now, for additional resources, the Neurologic Clinical Journal has a lot of great research papers about treatment of non-motor and motor symptoms of PD. And for patients with Parkinson's disease, Parkinsons.org has great information for you.